guys, so today we're going to talk about nursing care of the child with a cardiovascular disorder. So cardiovascular diseases in children are diseases of perfusion. Perfusion is defined as the mechanisms that facilitate blood through the tissue. So there are two categories of cardiovascular disorders, and those are congenital and acquired. Within those, there are four types of congenital diseases. There are those that increase pulmonary blood flow, those that decrease pulmonary blood flow, those that obstruct the blood flow, and mixed blood flow disorders. What I want you to do is to try to focus on separating these disorders into these four categories. Once you've memorized the categories and which specific cardiovascular diseases or disorders go where, then you can have a basic understanding of what to expect and how to care for that child. Okay, so this is a very confusing picture. Basically, here's how we break it down. In utero, the fetus doesn't breathe through its lungs, obviously, right? It doesn't breathe through its mouth and then disseminate oxygen through its body using ventilation in the form that we're used to hearing about it. So there's an opening called the foramen ovale that lets blood go back and forth between the atrium of the heart. So blood goes back and forth between the right atrium and the left atrium. This is occurring in utero. There's also an opening that's called the ductus arteriosus, and that shunts blood away from the pulmonary circulation. So we're growing a body in there, and since it isn't breathing, lungs aren't really that important, right? So we don't need to feed the lungs with healthy blood. The fetus needs to keep the body and the brain fed, so that's what its little systems are focusing on. Okay, so this is what happens after birth. Immediately after birth, when a baby takes its first breaths, some changes occur in the pressures. So in utero, there's a high pulmonary vascular resistance because we're kind of keeping blood out of that space. After birth, that resistance decreases. That allows some blood to go into the lungs and to feed the lung tissue because now it's time to keep them healthy. The right atrial pressure now decreases. Then the left-sided heart pressure increases, and with the decrease on the right side and the increase on the left side, it pushes the foramen ovale closed. And then the ductus arteriosus and the ductus venosus close as well. So immediately after birth, and for a little while, sometimes a couple months, the right ventricle is a bit more dominant in musculature, in the wall thickness, than the left side, and it does kind of dominate the function of the heart, but this changes over time. Okay, so when we are taking or performing an assessment of a pediatric patient with a cardiovascular issue, we need to be very thorough in the health history. So we want to ask about the symptoms and the progression of the symptoms. We want to talk about the treatment, home meds that they've been on. This also goes into all of these different symptomatures or symptoms like orthopnea, dyspnea, vomiting, failure to thrive, we see often, sweating or diaphoresis, tachypnea. We're also going to ask about if there were problems immediately after the birth. Were there any chromosomal abnormalities found? Was the baby premature? Does anyone in the family or mom have autoimmune disorders? Then we're going to get into the inspection. So I have loaded the cardiovascular board or the cardiac board onto the Module 2 home page, week 2. And that board should have some good pictures of cyanosis that we would see in an infant. There is edema that occurs in infants. We see a lot of puffy eyelids. Puffy eyelids can occur immediately after birth and have nothing to do with anything bad, but you'll notice from one assessment to the next if there is increased facial edema or periorbital edema. Edema of the lower extremities, so they're little tootsies. It's going to be characteristic of right ventricular heart failure in an older child. Again, we talk about clubbing of the finger and toes because, because they are dealing with chronic hypoxia due to severe congenital heart disease. And if we see fever, we think infection. Respiratory rate, rhythm, and effort is going to be affected with cardiac diseases. We're going to palpate for pulses bilaterally in the upper and lower extremities. Obviously, with an infant, you are not going to palpate radial or pedal pulses very often. If you find pulses are weaker in the lower extremities, that can be indicative of coarctation of the aorta. And then superbounding pulses is patent ductus arteriosus possibility. So we're going to palpate the abdomen, but to be honest, early on, palpating an abdomen and actually feeling that the liver is swollen in hepatomegaly is difficult. So this might be something that you learn as you go. But hepatomegaly can be symptomatic of right-sided heart failure. We're going to listen to the apical pulse, like I told you guys, for a full minute. We're going to look for it or listen for irregularities, murmurs, and the rate. That being said, infants very frequently have a variable heart rate that kind of goes along with their breathing pattern. So, and sometimes this can also go into childhood. They take a breath in and the heart rate slows. They breathe out, the heart rate speeds up again. That is not necessarily pointing towards disease. Usually in a child that you're going to be assessing for a cardiovascular disease, we will take blood pressures in the upper and lower extremities. And with a lot of infants, the doctors will order blood pressures on all four. So get in the habit of checking those orders for stuff like that.